Hi, everyone. My name is Omid Salmi. I'm a physician trained in internal medicine and geriatrics. Today, we'll be talking about delirium. When I was going through my training, I found that it was very difficult to learn and then to teach others about the different geriatric syndromes. Delirium is a prototype amongst all of them of a great geriatric syndrome. There are a lot of really great resources out there, but I found it was really difficult to translate that into clinical practice. So I created this tool for an interactive flow sheet that we'll be able to go through together today. This can be found at GeriGuides.com, and we'll be walking through that together right now. This is the overview of the interactive flow sheet. We're going to be starting at the very top about when to suspect delirium. And by following the flow sheet, we'll be able to walk down every major clinical decision-making process over here. So when do you suspect delirium in an older adult? Well, delirium is a very common thing that we see. And I kind of think of delirium as acute brain failure. It's an acute change in mental status that's characterized by inattention and fluctuation that's due to precipitating factors or noxious stimuli. And as you can see, it is extremely common the more sick that we become. In the ICU, it's anywhere from 25 to 80%. On the floors, either on the surgical or inpatient ward, it can be as high as 60%. Even in the post-acute setting in the skilled nursing facility or the nursing homes, you can see it in 30% of patients. And then once we go to the emergency room, it drops down to about 10 to 20%, and out in the community, about 1 to 2% or so. And what I want to highlight over here is that while anyone can get delirium, it is a common geriatric syndrome because of the protective physiologic and cognitive reserves decline with age. And one of the really key things that we want to focus in for delirium is 30 to 40% of cases are preventable. So there's a lot of room for optimization. So now that we know when to suspect delirium in an older adult, it comes down to how to assess delirium. There are different assessment tools out there. The one that I would recommend using is the confusion assessment method, which has these different criteria. So the CAM criteria has 4 things. You need to have the first 2, which is an acute onset or a fluctuating course, and the presence of inattention. In addition, you need either disorganized thinking or an altered level of consciousness. In addition to the CAM criteria, there's also the DSM criteria that I have listed over here. But here's the thing, if you're not trained in psychiatry or how to evaluate for these things, it can be really subjective to kind of say that is someone having disorganized thinking, what does that really mean? For someone who's just starting out, I would recommend using a validated standardized tool, such as the 3D CAM, which is a 3-minute operationalized version of the CAM. So you can click here and you'll have a direct link to the CAM. And what I do is I pull this up on my phone through this tool and go through the questions with the patient. So the first part of it over here are 10 questions that you read to the patient, and you can see that you can either mark them incorrect or correct, and each one is evaluating one of the 4 CAM features that I have listed over here. So for example, when you ask the patient during the past day, have you ever felt confused? And the answer is yes, well, that's kind of assessing for an acute onset for them or a fluctuating course. Questions 11 through 20 are things that you're going to be assessing as the observer. And then there's also optional 21 and 22 questions over here as well. And by walking through this, you'll do a systematic approach to evaluating the CAM. Now, if you need more expertise on how to administer the CAM, I have a link to the training manual over here. The 3D CAM is really great for floor patients, but for those who can't speak because of intubation or another reason, there's an ICU CAM, and I have those linked over here as well. So after you've done your formal CAM assessment, you can say whether the patient has delirium, in which case you'll be going to the right of the algorithm here, or if they don't have delirium. If they don't have delirium, chances are the reason why you're suspecting this is because of altered mental status. I have a listed differential diagnosis over here, but the one I really want to focus on is the presence of dementia. The key thing about dementia to differentiate this from delirium is that dementia is more of a chronic, gradual worsening of someone's cognition. It should not be an acute worsening that's happening. The reason why this gets so misinterpreted for delirium is that sometimes people who have advanced dementia will have trouble with orientation questions. So they will screen positive on automatic screening tools that are out there. However, the thing is, when you're talking to someone with most types of dementia, they'll be present in the conversation, but they just don't have the cognitive ability to respond appropriately to your questions. On the other hand, someone who has delirium, they have that hallmark of inattention. So when you're talking to them, they physically can't stay present with you in the conversation, and they start going off in different directions there. In addition, I also want to highlight the presence of Lewy body dementia. This is a type of dementia where it has deficits in people's ability to maintain attention as well. So it's not uncommon where people with Lewy body dementia, they'll come in multiple times with delirium, and we'll find out that there's no underlying cause for it, and it's actually the onset of Lewy body dementia. The classic teaching is differentiating between delirium, depression, and dementia, and I have this Toronto Region Best Practice Long-Term Care Initiative that goes through the differentiating factors over there, as well as the other differential diagnoses. However, it's always safe to assume that someone has delirium while you're ruling out other etiologies, because when you evaluate for delirium and you treat for delirium, you're essentially giving the patient the best geriatric medical care possible. Now, if they have screened in positive for delirium, you want to go and identify the delirium subtype. And if you have this at your hospital, consider a geriatrics consultation. So as far as the different types of delirium go, we have hyperactive delirium, and this is the classic one that I think a lot of people think about when they think of delirium. Someone who has a lot of agitation, who's feeling hypervigilant at all times, they're restless, sometimes they're aggressive. On the other hand, you have the hypoactive phenotype, and this is someone who has more slowing of their movements. They look like they're apathetic, not really interactive with much. They're slow to speech, and they just kind of appear sedated. The most common type out there is actually mixed, where people will go from hyper to hypoactive. And the reason why it's so important to classify what type of delirium someone has is while you're taking care of it in the hospital or in this particular setting, it's going to be easy for you to know what's going on. But as soon as they move to the next setting, and albeit the outpatient setting or the skilled nursing facility, a new provider is going to come and take over, and they're not going to have any idea that this is an acute process that's going on or what to expect. They might get misdiagnosed with having dementia. There's another type of delirium that's subsyndromal delirium. It's an ongoing area of research, but we think that it has to do with delirium that doesn't quite meet diagnostic criteria and likely a more mild version of delirium. In the research studies that have been found in people who have subsyndromal delirium but not frank delirium, they do find that they have worse outcomes, but not quite to the extent of delirium and not quite as good as if you don't develop delirium. And then finally, why would you consider consulting geriatrics? Well, there have been studies that have been out there that show that if you consult geriatrics, it can reduce the rate of delirium by about 30%. And we'll revisit this topic in just a little bit. So now that you've gone through and you've diagnosed the delirium, you want to go and implement our standard prevention or treatment checklist, which is non-pharmacologic in scope. So there are 5 main aspects that you want to do for everyone that has delirium. Address their underlying medical issues, reduce their psychoactive drugs, reorient frequently and provide reassurance, maintain safe mobility, and optimize their sleep. Just by doing those 5 things, or by consulting geriatrics, we can reduce delirium by 30%. So as far as addressing the underlying medical issues, we're going to talk in a little bit about how to identify and treat the underlying issues, but that's a key thing that you want to do. When someone has delirium, oftentimes they can't tell you that they're in pain. So assess and consider treating their pain. Most people should be considered for doing a gram of Tylenol 3 times a day or at a lower dose if they're cirrhotic. And if someone has good reason to be in a lot of pain, it is good practice to consider doing the lowest effective dose possible of opioids. And the classic example of this is someone who has a pressure ulcer that's really painful, or someone who's just had a fracture. That pain in and of itself is going to be a main driver of the development and propagation of delirium. So treating it with an opioid is good practice. Other thing you want to do is, again, these people likely won't be eating and drinking due to their delirium, so consider a nutrition consult on them. And if they have dementia, a speech therapy consult to think about different strategies to encourage drinking and hydration of the patient. Lastly, they're very prone to developing constipation and urinary retention. So you want to make sure they have a good bowel regimen and that they're not developing acute urinary retention as well, because both of those things can make delirium prolonged. You want to reduce their psychoactive drugs as well. So I have a couple different tools linked over here. The first one is this anticholinergic calculator. It's the ACB calculator. You type in all their medications and it'll tell you what the anticholinergic burden is. It's a nice way to get a quick view about how many anticholinergic medications someone's on. Sedating medications, we definitely want to avoid using those when someone is having delirium. If we click over here, we can find that it's an American Geriatrics Choosing Wisely campaign, which states don't use benzodiazepines or other sedative hypnotics in older adults as a first-line choice for insomnia, agitation, or delirium. The only time you want to use that is if someone's in alcohol withdrawal or delirium tremens or has severe generalized anxiety disorder. The use of benzodiazepines in particular can worsen delirium and prolong it as well. And then finally, muscle relaxants, things like methocarbamol or cyclobenzaprine. Those class of medications predominantly work by causing CNS depression, which will then relax the muscles. Again, if you can avoid using them, all the better. Not only do they have a high anticholinergic burden, but in addition to that, they also cause sedation of the patient, which acts centrally, which can prolong delirium as well. There is a master list of deliriogenic medications that I have listed over here. These are all the different medications that are out there that we think that are associated with it, and it's not even an exhaustive list. This was adapted from UpToDate. I will highlight a couple things on here. One is that some of these medications, like cardiovascular medications, like beta blockers, while they have an association with delirium, if the benefit derived from being on the medication is high, you want to keep them on it. I want my person who just had an MI to be on a beta blocker because that's going to be protective to them. And most likely by treating their underlying medical condition, that'll be more beneficial too. So all this is going to be having to weigh the pros and the cons of therapy. You just want to minimize the number of medications that aren't necessary for someone who's having delirium. So back to here as well, the third thing that we want to do is frequently reorient the patient and provide reassurance. Now, one caveat for this is if the reorientation is causing distress, like constantly asking the patient, what day is it today? What year is it? You might want to avoid doing that because we're not here to agitate the patient because that can make things worse. What we do want to do is encourage family to be at the bedside or having a patient care attendant who's trained in talking with patients with dementia or delirium, and so that they can reorient the patient when needed and help keep them engaged in the present situation. Having family education is really important too about the importance of their role. So I have this information handout from our Duke library over here that was developed by our geriatricians, which talks about what is delirium and things that the family members can do to help improve the loved one's care. Also consider having an occupational or speech therapy consultation. Keep the whiteboard updated, and again, trying to keep their brain grounded in reality as much as possible. And this is where making sure that their sensory impairments are being tended to by either the use of glasses, hearing aids, or listening amplifiers is really important as well. We want to maintain safe mobility for our delirious patients. By far and away, one of the worst things that we can do is keep them in bed all day, because not only are they not going to be as active, which is going to make their underlying medical condition possibly get worsen their underlying constipation, precipitate urinary retention, but it can also make them weak so that once they leave the hospital, they're going to be more likely to fall. So on that note, we want to remove all non-essential tethers. So constantly be reevaluating whether you need to have Foley catheters, IVs, or cardiac monitoring, any type of tether on the patient. In addition, we really should not be using physical restraints on our patients unless they're absolutely necessary. This is, again, a Choosing Wisely campaign from the American Geriatric Society. Don't use physical restraints to manage behavioral symptoms of hospitalized patients with delirium. We know that it can worsen outcomes and it can also prolong delirium as well. Think about it. If you're someone who's confused about what's going on and you have delirium and someone's strapping you down, that's going to make you feel even more agitated to what could be going on. Other thing that's really helpful is to have a physical therapy consultation as well with occupational therapy, and a goal to mobilize the patient at least 2 to 3 times a day. Just that very activity of engaging in daytime activity, moving around, it's beneficial for so many different things, but also for getting the patient to get back into their normal routine that they would be doing at home. The last thing that we want to do as well is optimize sleep. Sleeping is very difficult to do in the hospital, and it's made even worse by a lot of underlying insomnia that patients have before they even come in. So good sleep hygiene and keeping the lights on and having activity during the daytime is going to be key. Avoid naps as much as possible. And this is where the family and patient care attendant can come in. You want to have cognitive stimulation tailored to the patients, and think about using chaplain visits, music therapy, pet therapy, or other things as well. And like we were talking about before, consider physical activity. We want to reduce nighttime interruptions as much as medically possible. So if someone's fairly stable and you think that they don't need to have their overnight vital signs, then by all means, let them sleep from 11 to 5 a.m. Same thing with labs as well. As far as sleep medications go, in general, the medications that we have aren't very effective, but you can consider doing melatonin 3 milligrams every night to help out with sleep, or the judicious use of trazodone as well. The one thing I will caution about both of these medications is that if you notice that it's making your patient too sleepy the next day, you might want to taper back on that, because again, the ability to mobilize safely and to have activity during the daytime is going to be much better and more impactful than a low dose of melatonin or trazodone. So why are we making such a big deal about these recommendations? Well, this article kind of goes into that. So if we go on here, we can see the post-operative delirium in older adults best practice statement from the American Geriatric Society. If we scroll down a little bit, you'll see that the ability to do these 10 things that they have listed over here has been shown to successfully reduce the incidence of delirium by about 30 to 40%. We should pause for a moment and just think about that. We have no medications out there that can reduce delirium by 30 to 40% or by any percent at all. But doing these 10 things, these standard therapies that we've kind of gone through before, has been shown to be reducing the rates of delirium by almost 40%. I think that's just absolutely incredible, and why it's so important to really focus on these standard interventions that we have out there. It's our most powerful tool in the fight against delirium. This link over here will take you to another study that showed that the same effect is seen by doing a geriatric consultation, because in geriatrics, we tend to focus on those standard interventions as well. So now that you've gone through and implemented your standard delirium treatment for everyone, you want to do two things in tandem. First is want to evaluate whether the patient with delirium is a danger to themselves or to others, and then also to do your full medical evaluation of what's going on. So we'll start off by asking, is the patient a danger to themselves or to others, or having distressing psychosis? The reason why we ask this question is because antipsychotic use should be reserved only for those who have severe agitation, who risk interruption of essential medical treatment, someone trying to self-extubate themselves or to take out their tracheostomy, those types of things where not intervening on that type of behavior would be more dangerous to the patient than giving them an antipsychotic. If they're trying to injure themselves or injure other people, for example, hitting out at nurses, we definitely want to go and address that behavior. And then in addition, if they're experiencing severe and distressing psychotic symptoms, such as hallucinations, delusions, or paranoia as a result of their delirium. And the caveat with this is that it should be distressing to the patient themselves, because if it's distressing to family or to providers, we can step in and educate about that. What we're really looking for is it distressing to the patient themselves? So why do we limit the use of antipsychotics to these three key criteria? Well, there have been a lot of studies out there looking at the use of antipsychotics. So we can say that at this point, we know that antipsychotics do not resolve delirium. There is no benefit in giving someone antipsychotics to shorten their duration of delirium. And this was seen in a large ICU trial that was published in the New England Journal, a randomized control. And then there was a massive 2019 systematic review that came out as well. In addition, there is no role for antipsychotics to prevent delirium. Again, there was another systematic review published in 2019. But we do know for sure that antipsychotics are associated with higher mortality in the form of cardiovascular events, infections, and other things. It's associated with increased length of stay in the hospital. And we also have good reasons to think that antipsychotics can prolong delirium. A lot of antipsychotics, especially when they're used to excess, can make people become too sedated and flip into hypoactive delirium. And a lot of the antipsychotics that we use actually have a high anticholinergic burden. And if we believe that anticholinergic medications can precipitate delirium, it stands to reason that medications such as antipsychotics that have a high anticholinergic burden can prolong delirium as well. So the pearl over here, again, is to emphasize that antipsychotics do not resolve or prevent delirium. They only treat the hyperactive symptoms. And that's the only reason why we want to use them in a patient, knowing that they are associated with a lot of harm. So if the answer to this question, is the patient behavior a danger to themselves or to others, or they're having distressing psychosis, if the answer is no, we don't want to give them any antipsychotic therapy. If the answer is yes, then we have to determine, is it safe to give them antipsychotics? And the question that you want to ask is the QTC prolonged? And we use an arbitrary cutoff of greater than 500 milliseconds. The reason why we use that is that some studies linked over here show that the incidence of torsades, the points, increases to 0.7% and has an inflection above 500 milliseconds. But that's not the only criteria that we look for. You also worry if someone's increasing their QTC more than 60 milliseconds from baseline, because that also carries the same risk of developing torsades. So it's important to monitor these people with serial EKGs, especially if they're requiring multiple or high doses of antipsychotics. To my knowledge, we have no guidance on how often to monitor EKG, so that's more left to clinician discretion. If someone does have a high QTC and you think it's really important to use an antipsychotic, then it's going to be important to treat the reversible causes of QTC prolongation. And I have them listed over here, and this will link you to the up-to-date article that talks more about that. Finally, it's okay to recheck EKGs and to see if the QTC goes down, and constantly reevaluate the need to see if you really need to use antipsychotic therapy. I put a quick note in here that because we were talking about the cardiovascular side effects of antipsychotics, we normally think about QTC prolongation, but long-term use in particular of antipsychotics are known to cause tachycardia, cardiomyopathy, and myocarditis as well. So there are a lot of different cardiovascular complications of antipsychotics. So if the QTC is prolonged, you really want to avoid using antipsychotic therapy. And this puts you in a tough situation. It's going to be really important to revisit and emphasize the standard interventions that we talked about before. You really want to focus in on involving the family as much as you can, particularly for the reorientation and prevention of self-harm. And if restraints are used, you want to constantly reevaluate the need to make sure that we're not keeping restraints on unnecessarily when we could take them off. This is a very controversial point over here, but if an antipsychotic is strongly desired, aripiprazole theoretically has the lowest risk of QTC prolongation, but it has not been well studied in delirium. In addition, we don't have any clear guidance on the dosing of it, and it may not be possible for someone who does not want to take an oral medication. And I'll explain why down here. So aripiprazole comes in a tablet form that you take orally or intramuscular, and the starting dose is anywhere from 1 to 2 milligrams. The oral dose, you'll see pretty much a peak effect of it within 2 hours. So you could think about redosing it then. However, with the maintenance frequency is about 1 time per day. The maximum daily dose is 15 milligrams. But again, if you have a patient who is requiring antipsychotics and they have a prolonged QTC, so you're really thinking about it, chances are they're not going to tolerate an oral medication. So the only other route of administration of aripiprazole that you have is intramuscular. But this peaks after 4 to 7 days. So there isn't any good guidance about how often to redose the medication. So as a result of this, I personally do not use it, and I don't know of any other geriatrician at my institution who uses it, but it is an option out there, and I wanted to bring it up here because there are some people that do use it. I feel like if you're getting to this point, you really want to get geriatrics or psychiatry involved. If one were to use it, it is a very clean medication. There aren't any renal or hepatic adjustments you need to make, and the side effect profile is pretty insignificant. There's the low risk of extrapyramidal side effects, prolactin elevation, sedation, anticholinergics, or orthostatics. The alternative to using an antipsychotic is using a benzodiazepine. We talked about before how we want to avoid benzos as much as possible in someone who's delirious unless it's due to alcohol withdrawal, because it will probably prolong delirium and it can worsen the severity of their delirium as well too. And then finally, it's perfectly okay to recheck someone's EKG to reevaluate whether their underlying medical condition has changed their QTC to the point where giving antipsychotics would be reasonable. But let's say that their QTC is not prolonged. So at that situation, you can consider using a low dose antipsychotic for the shortest amount of time. So a couple of quick pearls before we get into the selection of antipsychotics that I have listed in an additional interactive flowchart over here. One is that no antipsychotic has ever been shown to be superior to another one. So using a first generation like haloperidol compared to an atypical antipsychotic like olanzapine or Seroquel, they're roughly thought to be equivalent. Their side effect profile would change though, and that's how we should be thinking about the selection of the medications. It should be based on indication, comorbidities, and side effect profile. And lastly, all antipsychotics are off-label in the treatment of delirium. So everything that we're doing is an off-label use. And one thing to note, we talked about the increasing mortality rate with antipsychotics. So it's important to note that antipsychotics have a high risk of developing hypoactive delirium, especially if you overdose your patients. And in addition, you can prolong their delirium as well for reasons that we talked about before. In addition, they are associated with the black box warning of a 1.7 time increase in mortality. And the study that this was shown in was an increase from baseline of 2.6 to 4.5% over 10 weeks. Think about that. We were able to increase someone's risk of mortality by 1.7 folds from 2.6 to 4.5%. Again, it's very hard to think of other treatments that we have out there that increase someone's risk of mortality by that much. So the decision to use antipsychotics should not be taken lightly. Now, how to go about choosing what antipsychotic to use. I created another flowchart over here, and this is my way of thinking through it because there are certain situations where some antipsychotics would be better than others based on the side effect profile and what other comorbidities the patient has. So just as a reminder, if you are thinking about using antipsychotics, if your institution has it, please consider doing a geriatric medicine consultation. First question you want to ask yourself is the patient in alcohol withdrawal or have a history of neuroleptic malignant syndrome? If the answer is yes, really you're stuck with benzodiazepines. And if they are in alcohol withdrawal, use your clinical judgment for dosing. And if they just have generalized delirium, start at the lowest dose possible, and you can always redose them as needed. So what I would recommend is thinking about lorazepam 0.25 to 0.5 milligrams. And really keep in mind that benzos can cause paradoxical agitation and excitement and increase their confusion. So that's the risk you're taking by giving benzodiazepines. However, if you're in alcohol withdrawal, benzos are the treatment of choice. So everything I just said right now is moot, and you want to treat them for their withdrawal based on withdrawal-based dosing. If they don't have alcohol withdrawal or a history of NMS, what you want to do is determine whether the patient has Lewy body dementia or advanced Parkinson's. If they do, you want to choose a medication that does not have high level of dopamine 2 receptor antagonism, like haloperidol, olanzapine, or risperidone, because these patients are dependent on their dopamine. And if you cut that off by using a medication like Haldol, then what will happen is that you can worsen their Parkinsonism and precipitate a neuroleptic malignant syndrome. So the first line therapy is going to be using Seroquel or quetiapine 6.25 to 12.5 milligrams. And if you can't give that for whatever reason, then think about doing clozapine. Now, clozapine has a whole host of its own side effect profile. So if you are thinking about clozapine, I would really consider getting psychiatry involved. The recommendation for using quetiapine as a first line and clozapine as a second line comes from the Lewy Body Society recommendations that you can see over here. Now, if they don't have Lewy body or advanced Parkinson's disease, then do they have a history of extrapyramidal symptoms with prior antipsychotic use? Things like acute dystonia, drug-induced Parkinsonism, akathisia, tardive dyskinesia, or esophageal dysfunction. If they do, you want to avoid the use of a typical antipsychotic like haloperidol and consider the cautious use of the lowest effective dose of an atypical or second generation antipsychotic. This would be everything that we have listed down here from quetiapine, ziprasidone, olanzapine, or risperidone. And the pearl is that all antipsychotics carry the risk of extrapyramidal side effects, but haloperidol carries the highest risk and is greatest when you give someone more than 3 milligrams a day. Next question I ask myself is, does the patient have terminal delirium, which is delirium that we typically see at the end of life in the dying process? And if the answer is yes, Haldol is the standard of care that we use for those patients. And you can actually consider, if someone's requiring higher doses of haloperidol, low doses of benzodiazepine to help out with that agitated delirium. And I have a link to a review here as well. Finally, the last question I ask myself is, do you need a medication that's going to have a very fast onset of action because they are an immediate danger to themselves or to others? If the answer is yes, then you're thinking about using haloperidol and olanzapine. And if the answer is no, then you really have the full gamut of options available to you. And the full gamut is 5 options here. So haloperidol, which is a typical antipsychotic first generation, and then the second generations below it. Seroquel, ziprasidone, olanzapine, and risperidone. I have all the different routes of administration over here for you as well, the starting doses, and how often you should think about reassessing them based on what the expected onset and peak effect should be. So for example, for haloperidol, you should be able to see a good effect of that within 15 minutes if you give it intramuscular, and after about 30 minutes if you see orally. I would really caution you about redosing the medications before that time because, again, what we want to avoid is someone getting too sedated and flipping into hypoactive delirium. In this column, we have the maintenance frequency, so how often you would want to think about dosing them. For example, olanzapine, a maintenance frequency for that would be 1 time a day, whereas these other medications are twice a day. Their maximum daily dose, which is listed over here. This is the olanzapine maximum daily dose is a bit controversial. There's some people that think it's 10 milligrams. Some people think that it should be 20 milligrams. Renal adjustment considerations that you need to have in mind, hepatic adjustments, and then finally the side effect profile. So extrapyramidal side effects, prolactin elevation, the degree of sedation that you get with certain medications, and anticholinergic effects. I want to spend a little moment on anticholinergic effects because it's something that we don't think about often. So if someone is having some anticholinergic side effects, for example, they're having signs of acute urinary retention, or they're having really bad constipation, then perhaps using a medication like quetiapine or olanzapine aren't a good idea because they do have a moderate amount of anticholinergic burden. And in that situation, you might be better off with going in with one of these other medications that has a lower burden for them. The other thing you want to keep in mind too is the orthostatic hypotension risk. So Haldol has the lowest risk, and everyone else has a moderate to high risk, with Seroquel or quetiapine thought to have the highest risk of orthostatic hypotension. So if someone came in with a fall due to orthostatics, probably not the best option for them to give them some quetiapine. And then finally, we have the risk of QTC prolongation. So as you can see here, the use of haloperidol IV carries the highest risk, as well as ziprasidone, whereas these other medications have a moderate risk of QTC prolongation. Now, another thing to keep in mind is that this table in these doses and frequency of dosing was developed for an older adult. And the more frail they are, the more you're going to have to err on the side of a lower starting dose. If you have a really robust older adult, then who's very violent, you might have to start with a higher dose and titrate from there. At the end of the day, though, the mantra in geriatrics, you can start low and go slow. You can always add more, but you can't take back medications that you give to a patient. And then for some background information about how this table was made, I put some information in this over here, as well as some tips for tapering off the medications in the future. Now, so at this point, we've addressed whether or not the patient's behavior was a danger to themselves or to others, or having distressing psychosis. At the same time, it's going to be really important to do your underlying evaluation of what's going on with the patient's delirium and how they got there. So first thing you want to do is perform a really good history and physical. So I took this from Dr. Enue's her article from the New England Journal, and she has a really nice outline for the history, vital signs, and physical and neurologic examination that you want to do over here. But the gist of it is saying that you really want to do a good geriatric assessment for the patient. Check their baseline cognitive function and whether anything's really changed within the past 2 weeks by someone who knows the patient well, a family member at home or a staff member at the facility that they live in. You also want to know, is there anything new that could have happened? A change in their disorder, a new diagnosis, and make sure you do a complete review of systems. You want to review all medications that the person's on, especially focusing on over-the-counter medications or oral preparations. And for whatever reason, a lot of people love to take PM medications like Tylenol or Advil PM, which has the Benadryl in there as well, or diphenhydramine, which is a very common precipitant of delirium. And then in addition, the more medication that someone's on, the more likely there is to be a drug-drug interaction. So on the note of looking at drugs, again, I linked over here directly to the slide that we had before about drugs believed to cause or prolong delirium. Review for alcohol or sedative use. Again, you're trying to see if they have an underlying withdrawal syndrome that's going on. Assess their pain or discomfort, urinary retention, constipation, or thirst. Make sure that their vital signs are within normal limits, and if they're not, try to figure out what's going on over there. Think about taking their postural vital signs or orthostatics. And then you really want to do a good physical examination and a evaluation for any focal neurologic signs and symptoms or any signs of a meningeal process that could represent a meningitis. So now that you've done your history and physical exam, you want to identify whether you can find any precipitating or predisposing factors. So I want to come back to this slide. Let's go to the next one really quick, just to talk about the pathophysiology and what type of model you should think for approaching the predisposing and precipitating factors. So there's another great model that Dr. Enue had in one of her review articles talking about the multifactorial model of delirium in older adults, and that it's an interplay between the predisposing factors or someone's vulnerability and the precipitating factors or the insults for the development of delirium. And the way that I do it is by just thinking of it as analogous that dementia and delirium are like acute kidney injury and chronic kidney disease. In this situation, chronic kidney disease is the dementia, and the acute kidney injury is like the delirium. So think about it. If you're someone who has CKD, then smaller and smaller things, depending on how advanced your CKD is more likely to precipitate your AKI. Someone who has CKD stage 5, they could take one single dose of ibuprofen and that could precipitate an AKI. Whereas if you're a 20-year-old with a perfectly normal kidney, you can take multiple doses of ibuprofen and be able to maintain a good kidney function. So the pearl here is that it is an interplay between your predisposing factors, your vulnerability, and the precipitating factors or the degree of the insult that's going to be happening. So the more advanced someone's dementia is, or as we're going to see in a little bit, other factors that will determine how healthy they are at baseline, the more vulnerable their brain is, so that they can have smaller and smaller noxious stimuli that can precipitate their delirium. And when a patient becomes it's so advanced with their dementia or so frail or have so many medical comorbidities, it's not uncommon that after even doing a complete search, we can't find the cause of their delirium because what's causing it is such a small change in their baseline that our medical tests can't detect that. And the type of patient that I'm thinking about over here is someone who has end-stage dementia, who is essentially bedbound with a host of other comorbidities and who lives in the nursing home. those people are going to be so prone to developing delirium that the very fact of taking them out of the nursing home and to another location like the emergency room, that in and of itself could be enough to precipitate their delirium, something as small and as innocuous as that. Now, what is the underlying pathophysiologic cause of delirium? We don't really know. We don't have a unifying theory right now, and it's most likely going to be due to a combination of multiple different factors. There's one thought that a lot of people who are sick, especially due to sepsis and a whole bunch of other inflammatory conditions, may have a cytokine release that interrupts the CSF and makes it so that the brain bath that the neurons are in isn't working well, and that can precipitate delirium. Based on the observation that giving someone an anticholinergic medication like diphenhydramine or dopamine excess medication like carbidopa-levodopa can precipitate delirium as well, so perhaps there's a contribution from neurotransmitters. Ultimately, this is an area of ongoing research, and we're still not exactly sure what that is. But once we do have a better underlying pathophysiology, we hope to have better treatments that are out there. So now we're going back to the precipitating and predisposing factors. And this is again from Dr. Enue's review, where they lay out all these different predisposing factors based on prediction models that have been done before. I want to highlight that the presence of dementia or cognitive impairment is a very strong predisposing factor. If you've had a delirium before, if you've had underlying functional impairment so that you've lost your abilities to maintain your own IADLs or ADLs, the presence of a sensory impairment such as vision or hearing, and also your underlying comorbidities or the severity of your illness play a big role too. In addition, the presence of an underlying psychiatric history such as depression or alcohol abuse are also strong drivers of someone being likely to develop delirium. The other thing that we have in here is old age. We also know that for whatever reason, men, people over the age of 65, if you've had a history of falls, if you're malnourished, if you're on multiple psychoactive medications or multiple drugs in general too, those can also cause delirium. Now, the reason why you can see so much range in these numbers over here is that our current delirium prediction models are generally poor, and they're not usually externally generalizable from one institution to another, reflecting the heterogeneity in what causes delirium and also patient populations. But it is an area of ongoing research. The main takeaway from here is look at the different factors that are involved with someone being precipitated to delirium and think about how that plays into the patient that you have. As far as precipitating factors, the use of drugs, some types of restraints or tethers, medical illnesses, be it an increased serum urea, BO2 creatinine, serum albumin being low, or having a metabolic abnormality such as sodium, glucose, or potassium, an infection, a surgery, really anything medical can precipitate delirium, and the degree to which will vary on the severity of the underlying precipitating factor as well. So these are all the different things that can precipitate and predispose someone to having delirium. Now, after you've gone through and based on your history and physical exam and identified what could be a precipitating and predisposing factor, the key question to ask yourself now is, have you found things? If you haven't, then you need to search for additional precipitating and predisposing factors. And I have a list over here from a really interesting study that was done looking at consecutive people that were admitted to the hospital with delirium. And they found that most of them had some type of contribution of an underlying infection or some type of underlying electrolyte or volume abnormality, a drug intoxication or withdrawal, neurologic insults such as a seizure, subdural hematoma, stroke, or trauma, heart failure, and even 1% had a fracture. Now, one thing to keep in mind about infections is that not everything that has bacteria in the bladder is an infection in an older adult. And I have a specific GeriGuide that's on this that you can see as well. But the pearl here is that frail older adults have rates of asymptomatic bacteria approaching 50%. So whether or not someone's having symptoms, if you check their urine in an older adult, especially if they're institutionalized, they will likely have bacteria on the order of a flip of a coin. So the presence of bacteria in and of itself does not diagnose a UTI. In the presence of delirium, but in the absence of clear localizing symptoms, that bacteriuria may be a red herring. So it's important to continue to evaluate for other potential precipitants. And a lot of geriatric-based guidelines have come out right now, and even the IDSA have come out and said that urinary tract infections should be a diagnosis of exclusion, again, in the absence of sepsis or localizing signs and symptoms in the case of delirium. So again, that bacteria that you see in the urine, it doesn't signify an infection unless they have the presence of localizing signs and symptoms, sepsis, or you have done a full evaluation and you haven't found anything else to suggest that there's another process going on. At the same time, also think about additional predisposing factors. So you want to reevaluate the premorbid functional and cognitive baseline. And if you really can't find anything that's out there, think about Lewy body dementia, as we talked about before, as an explanation for why someone could have delirium without a clear precipitant. Now, if you still don't have an answer for why this person is having delirium, then you want to think about doing a further evaluation that I have outlined further, which is kind of in the same way too. So if you don't have underlying culprit, then go to an additional workup. So this workup was adapted from UpToDate and based on expert opinion. But the first thing that I would do is repeat all your vital signs with pulse ox, repeat baseline labs, including a CBC, CMP, MAG, and FOS, a VBG, an EKG, and consider getting troponins if you have any concerns for an underlying acute coronary syndrome, brain natriuretic peptide, and a CRP. If those are abnormal, you want to investigate the etiology of what's going on. If they are normal, then you want to, again, review the medication list and the social history to see if there's any medicine culprit or an withdrawal syndrome that's going on, because this represents 30% of the cases of delirium. Based on that, you want to address what you find. If you don't have an answer for that, you want to consider getting a head CT or a brain MRI, especially if someone's had a fall history. And if you find something from there, you want to investigate it further. If you still don't have an answer to what's going on, you want to consider doing a more in-depth infectious evaluation with blood cultures, chest radiograph, and a urine culture. And at this point, if anything comes back abnormal, it's reasonable to assess it further and to treat it. If you still don't have an answer, does the patient have an unexplained fever or nuchal rigidity that could suggest meningitis? If the answer is yes, you really need that LP to confirm the diagnosis. And if the answer is still no to everything, then you can get into these other lower yield tests that are out there, including a B12 and a folate, a thiamine, thyroid studies, an EEG to evaluate for seizures, a brain MRI instead of doing a head CT, because you really want to see with high resolution what could be going on. Think about checking drug levels to see if there's an anti-epileptic medication or a lithium level that could be abnormal, digoxin, for instance. You want to think about doing your heavy metal toxin screen, and then think about getting a lumbar puncture. If you do all those things and everything still comes back negative, I think you can feel rest assured that you've done a really comprehensive evaluation. So at this point, you want to go back and see if you've identified any other culprit, precipitating or predisposing factors. If your patient's improving, great. Then you can start thinking about getting them ready for discharge. If not, you want to consider a repeat evaluation for occult etiology, as we discussed. You want to reassess them periodically to make sure that there's no other precipitant that's came on. And you also want to evaluate whether the patient actually has prolonged delirium. So it's not uncommon that when I was on the geriatric consult team, we would get calls on patients that we had signed off on before because they developed new delirium, or people that we were following that developed prolonged delirium. And the key thing that you want to make sure is that you're constantly reevaluating them, because a new GI bleed, a new issue with urinary retention can present as new or worsening delirium. So always be looking out for predisposing factors and thinking about your standard checklist. Alternatively, there are people that can have delirium that goes on for about 4 weeks. We don't really know how much of the population this is. Some studies say 20%. We don't really have high level evidence to really draw good conclusions. But the key thing when someone has delirium that's gone on for 4 weeks or more is that these patients almost never recover to their pre-morbid physical or cognitive function. And they have a very poor prognosis, both in terms of mortality, but also functional status going forward. And the reason that you have to keep this in mind is that the longer someone is delirious, the more that noxious stew of things that the brain is sitting in is going on, and it can actually make someone's underlying dementia get worse or be the start of someone developing dementia as well too. So if you have a patient who's having it for 4 weeks and you can't find any other reason for what's going on, that could very well represent a new baseline for them. It might get a little bit better, but it won't ever be back to where they used to be before. So in either case, whether the patient's improving or not, and you've done your full evaluation, you want to prepare for an appropriate discharge. So like we were talking about, follow-up is really important because delirium can be the first sign of a pre-existing cognitive impairment and can accelerate the dementia pathology. Patients with delirium have worse outcomes in the hospital, both in terms of length of stay and mortality, and in the post-hospital setting. They are more likely to fall, have new functional dependence, and need to go to a skilled nursing facility. With all this said, it's going to be important to think about whether a geriatric outpatient consultation is needed, because geriatrics can evaluate a new cognitive baseline, address the underlying precipitants of their delirium, and also work to optimize their function as much as possible in a multidisciplinary nature. So where I practice, we have a geriatric evaluation treatment clinic that you can click over here or call to set an appointment. And at the VA, we also have a special referral in the GeriPack clinic as well, where you can see a patient with a special consult. The disposition for someone who's getting discharged with delirium is that I believe that the hospital is a very deliriogenic place, and that the presence of delirium in and of itself should not be a reason to keep someone in the hospital. And going to a post-acute care setting is usually better for a patient if they're medically stable. And if the patient does have a new functional deficit or a skilled nursing need, going to a skilled nursing facility is a great place for that person to go. If the patient is otherwise able to return home, keep in mind that because of their delirium and the waxing and waning nature of delirium, they will often need some type of supervision to ensure their safety. So on that note, consider providing them guidance, if applicable, on driving, medication administration, and managing finances. Be sure to include delirium on their discharge summary so that next time they see their primary care doctor or the provider over at the skilled nursing facility, they know that what they're seeing may not represent the patient's baseline, so they can intervene on that to optimize the patient as much as possible. And finally, if the patient is on delirium antipsychotics, please ensure that there's a plan to taper those antipsychotics, to discontinue them, or to reevaluate them on discharge. I can't tell you how many times I've seen patients who go home on antipsychotics, and the next provider who picks them up isn't sure exactly what those are for and might want to continue them going forward because they think it has to do to an underlying psychiatric illness as opposed to delirium. And then, like we talked about before, keep in mind that the long-term use of antipsychotics can cause many issues, among them tachycardia, cardiomyopathy, and myocarditis as well. So we want to be judicious with their use. So that's the end of our interactive flow sheet over here. I just wanted to conclude with a couple different points. The first one is that this is an approach that can be used. It's not to be replacing any expert medical opinion or to trump the advice of a psychiatrist or a geriatrician who could be involved with the case. This is one approach that I've developed after looking through all the different resources that are out there. So if you find a better approach that works better for you, all the better. Let me know about it. And if you have any suggestions for improvement or things that you'd like me to change with my approach over here, or even new resources as they come out, I have a link right here on every slide, which has suggestions for improvement that you can submit that will take you directly to a Google document. Well, I want to say thank you so much for listening to this, and I hope it helps out with understanding what delirium is and taking that knowledge into treating your patients with delirium. Thank you.